Hello, I'm Dr. Todd Cohen, and I am the Vice President of Medical Affairs at Blue Earth Diagnostics. Prior to that role, however, I was a practicing urologist in the North Carolina area in the city of Charlotte, North Carolina, for about 25 years. A lot of my time was spent treating men with prostate cancer. So before I get started with this talk, I really want to talk to you about a patient of mine from many years ago, and we'll call him Bob. So Bob came to me first with an elevated PSA level, or prostate specific antigen. And that was a sign back then to look for the presence of prostate cancer. So Bob underwent a biopsy, and he had a very low grade, low stage tumor, which I'll talk more about later. So it was a non aggressive tumor. And as we talked about what to do with this, he looked at me very, very sincerely and said, "What if we just watch this? What is going to happen to me?" And it was a very intriguing question because I met Bob about 20 years ago. And back then, if you had cancer, it was always treated. It was something probably more cultural and by age, because when I was a young man, everybody that had cancer was treated. So it was a very intriguing concept. Now I want to fast forward from when I first met Bob about 15 to 20 years ago to the present. And today, very low risk early stage prostate cancer like Bob's is very often, I'd say most commonly treated with something which we call active surveillance. And this is where we monitor the disease over time rather than do any definitive treatments upon the diagnosis. Now, this is not as widely accepted, mostly because of a lack of understanding of active surveillance, which exists in the prostate cancer community. And this really stems from the fact that, especially in my age group and men older than me, when people had cancer, you would think about treating them. There was never an option of not treating them. But this has changed a lot over the years because of our understanding of the nature of prostate cancer. So men most often think of something like active surveillance as doing nothing. But when we'll talk about this really isn't true. And active surveillance is actually a form of treatment. And when I discuss this with my patients, I said, don't look at it as doing nothing. We are actively involved in your cancer and will only treat if necessary. Now, thanks to recent advances in tools, we're able to monitor the prostate cancer a lot better. So active surveillance has become an increasingly useful treatment option in most men. So let's go on and talk more about active surveillance and why, if your doctor recommends it, you'll have a better understanding of what it actually is. So let's start with where there's confusion. And a lot of times this confusion stems from the idea that when people think about active surveillance, they're actually thinking about something else, which we call watchful waiting. Now, watchful waiting differs significantly from active surveillance because we're just watching and waiting for symptoms to occur. So we're not doing a lot of testing. We're not really actively involved. And in some cases, we even say to the patients, why don't you just come back if you start having problems? So most of the treatment, if we do treatment on patients that are under watchful waiting, is really for symptom relief or any obvious and significant signs of disease progression. So who would undergo watchful waiting? And these are typically men who are much older, who are unlikely to have any problems from the disease, or if they have some other severe health problems, let's say they've had severe cardiac or heart problems or severe other problems, other types of cancer, that's when we talk about, hey, this isn't going to bother you. So let's just, take a step back and only treat if necessary. How this differs from active surveillance is that active surveillance, just like the name implies, is active. And we're very involved with watching the cancer to make sure that it doesn't become a problem. Because the biggest fear of having cancer is this going to cause my death? Or is it going to cause such significant problems that my life is going to be ruined by the cancer? And that's when we would jump in and treat to prevent those things from occurring. So we'd only perform a definitive treatment, which usually is either surgery or some form of radiation, if the cancer progresses. So why can we even think about doing active surveillance? Well, many prostate cancers are very slow growing and very unlikely to progress. This is really what spurned the idea of uh, active surveillance, even as an option. So men can possibly safely forego either type of treatment, such as surgery or radiation, or some of the other less invasive treatments that are available, and avoid potential side effects, which can be significant. I mean, they can include incontinence, where men can end up in lifetime of wearing diapers because they're leaking urine all the time, and also sexual dysfunction with the inability to get an erection, which can cause significant lifestyle and emotional type problems, as well as health related problems just from the treatment of prostate cancer. So since many men under active surveillance or with that will never ever need any type of definitive treatment, we can proceed with watching these men for a significant amount of time. We'll talk about the research that shows how safe this is in just a minute. But let's talk about who our men are that are candidates for active surveillance. So let's start off with a little bit of context with prostate cancer in the United States. In 2024, it's expected that about 300,000 new cases of prostate cancer will be diagnosed. If you think about it, that's about 1 in 8 men in the US will be diagnosed with prostate cancer during their lifetime, which is a significant number and the most commonly diagnosed cancer in men. The average age of diagnosis is usually later in life. It's about the age of 67. Now, when we look at this, while there are about 300,000 new cases every year, about 35,000 men in the US will die from prostate cancer in 2024. So it's about 12% of it, where the other 88% will not die from the prostate cancer. So today, there are about 3.3 million men walking around in the US who have been diagnosed with prostate cancer and are living with it, either with having been treated or under active surveillance. So who are the best candidates now for active surveillance? Well, it comes to a lot of different factors. The first is age and life expectancy. And what I mean by that is, since prostate cancer is diagnosed usually later in life with the average age of about 67, if a man is very healthy and he's expected to live longer, the idea is that the cancer may progress during the lifetime and eventually cause problems. The younger age men are diagnosed, say in their 40s or 50s or early in their 60s, they have a longer potential life expectancy if the cancer doesn't cause problems. So we're looking at age as a potential factor in deciding who is good for active surveillance. Obviously, the older men who are not likely to have progression of disease in a short period of time are good candidates, but it's even good for men of younger age, and it's been shown to be safe. Again, we'll talk about that more in a minute. We also look at different clinical and pathologic variables. Now, what I mean by this is, when we diagnose prostate cancer, this is usually done with a biopsy or taking a little portion of the prostate out and looking at it under the microscope. This gives us an idea of how aggressive the cancer can be. And I'm going to say can be rather than is, and I'll explain that. The more aggressive the cancer, the less likely we are to recommend active surveillance. But in those that tend to be less aggressive, men are better candidates for it. We also look at PSA, or prostate-specific antigen, which is a blood test. Most often you're thinking, when I have a PSA, it's to see if I might have cancer. But actually, PSA is best served either to monitor men with cancer that we're watching, or men that have had treatment for their cancer, and to see if the cancer comes back. It's a useful tool for all of this, and we do use that to determine who may be a candidate for active surveillance. The lower PSA levels are better candidates, and higher PSA levels are less likely to be good candidates for a variety of reasons. So I talked about the pathology, and one of the things we look at in pathology is something called the Gleason score. Now, this was described by a Dr. Gleason, who is a pathologist, who looked at the prostate cancer under the microscope to determine how aggressive or non-aggressive the cancer may be. And so every time a cancer is diagnosed, a Gleason score is given. And this usually goes on a range between 2 and 10, where 10 being more aggressive and 2 being not aggressive at all. Most of the time, though, people don't believe that 2, 3, 4, and 5 even exist. So we're really looking at a Gleason score between 6 and 10, which can be a little confusing because usually when asked, on a scale of 1 to 10, how bad is my cancer? If we say it's really good, it's a 6, it's confusing. So its scale has been changed a little bit to go back to a 1 to 5 scale, where 1 is non-aggressive and 5 is more aggressive. So it's been adjusted that way by a group of pathologists and urologists who have looked at prostate cancer over the years, just to get rid of that confusion with talking to patients. So then we can take all of this information together and determine who is likely to have progression of their disease or disease that can cause a problem or possibly even lead to death from prostate cancer. And how do we do this? Well, we look at what we call prognosis. And the prognosis is determining how aggressive or what might happen, whether the cancer will cause death or the cancer can spread or become metastatic. And we have certain what we call algorithms, which uses all of these things I talked about: age, the PSA level, what the digital rectal exam feels like when you're having a rectal exam to feel the prostate, the Gleason score. And that's put into these algorithms, which help us determine the likelihood of the disease spreading or dying from the disease. And the most common one used today is something called CAPRA. And that will kind of give us an answer as to how aggressive the disease is. More recently, though, we have progressed past just these algorithms, which are very helpful, and have additional information that we can get from what we call genomic and genetic testing. There's a little difference between genomic and genetic testing. Genomic testing looks at the genes inside the cancer. And there are certain genes that tell us how aggressive the cancer can be or is likely to be, which is very interesting because then we can help getting these tests in addition to algorithms such as CAPRA and use this information together to really give us a better picture of how the cancer is going to react. This differs a little bit from genetic testing, which you may hear about, and it's usually thought about mostly in the idea of around breast cancer. But it's also very effective in looking at men with prostate cancer, because there are certain genes that you get from both your mother and your father that create your whole genetic makeup. Some of these genes can be abnormal, which can lead to cancers that may become more aggressive. And I say may because what the genomic tests tell us is what the cancer is doing today. And what genetic tests tell us is what the cancer may do in the future. So if we know that a cancer is not aggressive today by genomic testing and all these other clinical variables, but you have an abnormality in your genes that you're born with that may make your cancer more aggressive in the future, then we're less likely to do active surveillance because we're worried about something happening in the future. But if both of these testings and all the algorithms say that the cancer is less aggressive, well, then the person is a very good candidate for active surveillance going forward. Because then these men have a very low likelihood of developing disease progression or disease that could become fatal. So today, when we look at the whole idea that 300,000 men every year about are diagnosed with prostate cancer, nearly half of these men have low risk and low stage, which means confined disease to the prostate, which is unlikely to spread or require any immediate definitive treatment, again, such as radiation or surgery. So when we look at that, about 150,000 men in the US could potentially undergo active surveillance. So that's a huge number. And today, about 60% of men that are diagnosed with this will undergo active surveillance. So what do we do when we're looking at men undergoing active surveillance? Well, again, this is an active process. So we're monitoring these patients very, very closely with a variety of tests. So your doctor will discuss with you if you're a candidate for active surveillance and what these tests would entail going in the future to make sure that nothing ends up spreading or becoming potentially fatal. So the first of these is a subsequent biopsy. So a biopsy, again, is taking a little portion of the prostate and looking at it under the microscope to see what it's all about. Is it cancer, isn't it? And how aggressive does it look under the microscope? But when you have active surveillance, we want to watch this over time to see if there's changes. So although you have a biopsy done to make the diagnosis, it's usually recommended that subsequent biopsies be done in the future to make sure there are no changes, that the cancer doesn't become more aggressive. And that the timing of these is determined by, other clinical factors such as PSA and digital rectal exams, but also in what the original biopsy might have shown, how much cancer is present and what it looks like directly under the microscope. We do PSA testing. And like I mentioned before, most PSA testing is done as a screen to see if a patient is at risk of even having prostate. But for men that we know have prostate cancer, it's a good test to see, is the cancer growing? The more cancer, whether if it's growing and becoming progressively more, either within the prostate or outside the prostate, the PSA will tend to increase over time. Slowly increasing PSA is not as worrisome as rapidly increasing PSA. So this is watched periodically as well during the whole surveillance time period. We also look at, or I'll say feel, the prostate itself. So periodic rectal exams will be done. And this is just to see if we can feel something. Because most of the time these days, with the advent of PSA testing, certain imaging tests, we don't necessarily have to do as many rectal exams as we used to do in the past, because most cancers, unfortunately, you can't feel. And so when you can feel them, it is a sign that it may be changing. So if it goes from something that you can't feel to something that you can, this could be an issue which would make us stop our surveillance and proceed with some type of definitive treatment. The last thing we do is imaging. And what that means is some type of studies like X-ray studies. More commonly these days are something that we call an MRI, or magnetic resonance imaging, where we use magnets to actually look at the prostate. And we can look at it over time and see if things are changing. It's a good test, but it's not perfect. And it alone cannot help us determine if a patient who may be on surveillance would need treatment, but it's used in conjunction with these other ideas of biopsy and PSA testing, as well as the rectal exam. There are more imaging studies coming available soon that will probably be helpful as well in determining active surveillance, whether to maintain it or to come off of it, such as nuclear medicine studies, which are becoming much more approved these days, as well as much more sensitive, so we can get better ideas of what's happening within the prostate gland. Of course, if anybody has changes in symptoms that may be attributable to the prostate or trouble with urination, this may spark things as, let's get something done, because it not only will help with the cancer and get it out, but it also can affect some type of bladder control issues that somebody may be happening. So if the cancer is found to progress, this is when your doctor will recommend we need to do something more definitive to treat the cancer before it becomes a problem such as spreading or becoming a fatal type of cancer from what was not considered to be fatal before. So what does science say about all this? When we decide to do something like this, we want to make sure that it's safe. And there have been many studies looking at the safety of active surveillance. And probably the most famous one of these studies is called the PROTECT-T trial, which was actually done in England. And it started about 20 years ago. And this has been published in many journals. Initially, when the first years of the study came out, looking at safety and how men do. And more recently, though, the 15 years of men on this study was published in the New England Journal of Medicine back in the year of 2023, so just last year. And what this study looked at was about 1,600 men between the ages of 50 and 69 who had prostate cancer diagnosed by a PSA level that was above normal. And all of these men had what we call localized disease, or disease that had not spread outside of the prostate. These men were put into different categories. About a third of the men underwent surgery to treat the prostate cancer. About a third of the men had radiation. And about a third of the men were placed on active surveillance protocol. And they were watched over 15 years. And what they found was very interesting. They looked at men potentially dying from their prostate cancer. And the first thing they found is that very few of the men in any of these groups died from their prostate cancer within the 15-year follow-up period. But what's even more interesting is that the incidence of death from prostate cancer was nearly identical in all three of the groups. So whether they had surgery, radiation, or were followed with active surveillance, the incidence of death was the same in each one of these groups, showing that it was safe to actually watch this specific group of patients that had the low grade and low risk prostate cancer, and to not necessarily treat them, because at 15 years, the outcomes were about the same. The big difference, though, was that in the men in the active surveillance group, there was a smaller increase in the risk of developing spread or metastatic prostate cancer when compared to men that had either the prostatectomy or surgery or radiation treatment for their prostate cancer. But none of these affected the survival or living with or from or their disease, regardless of whether they had active surveillance or definitive treatment. So there are recent advances that show that we can follow the active surveillance and why it is a really good option for men that have a low risk of dying from their prostate cancer. So it's a great option today. And these studies, such as the PROTECT trial, have shown that it is very safe to do this. So going in the future, how will we better determine who is a good candidate for active surveillance? Again, we'll talk about genetic testing. We'll be able to determine just from a simple blood test or even from saliva if there are any abnormal genes that are present. And today we've identified just a few of these genes, but we're going to identify more and more that will either tell us that a potential prostate cancer is fatal or not fatal. We'll have molecular testing or genomic testing of the cancer itself when it's diagnosed. We have some of those tools today, and those are just getting better and better and better. We have imaging, the MRI tests, which again are not perfect for determining this, but they're a good way of watching and surveying the patients to determine if their cancer is progressing. And all of these together may make it so that it's not necessarily necessary in the future to keep getting these biopsies, which are invasive. And honestly, one of the main reasons why men don't stay on these, because they're tired after a while to just keep getting these repeated biopsies. What else is coming in the future? More imaging, the radionuclear testing, such as PET scans, which look at not only the disease presence within the prostate, but it can look at the activity or how metabolically active a cancer may be. And the more active it is, the more likely it is to be aggressive. So these are all things that we will use somewhat today, but more in the future as the technology gets better and better and better. So why would we even do active surveillance on a patient? Well, The big one is you may be able to prevent having to undergo surgery or radiation, which have potential significant side effects. As we talked about, either one of these treatments and some of the other treatments can lead to urinary incontinence or leaking urine constantly, or can cause erectile dysfunction. And it's very, very likely that even if surgery or radiation or other treatments may be needed in the future, all of these possible severe side effects can be postponed or even avoided in the future as technology for not only watching and with active surveillance, but also as treatment options become more and more or refined, that we will be able to avoid some of these bad side effects that are present today. So without invasive treatments, these side effects will be limited. Because if you have these, you can have real detriments to your quality of life. And that's part of what we're trying to achieve when we treat anybody with prostate cancer. So let's go back to my friend Bob that came in. And I call him a friend now because I've been watching him for over 20 years. We've been following him with active surveillance, with repeated biopsies, which are getting less and less because his disease hasn't gone on. And he is now 20 years from his initial diagnosis with no evidence of progression of the disease, a wonderful quality of life with none of the potential side effects that he may have had should he have undergone any type of definitive treatment. So why wouldn't you do active surveillance? Well, there's a variety of reasons. The first is, I'll say, psychological. It's the idea that you have cancer and we're not treating. And this a lot of times can play with your mind and with the ideas, gee, my toe hurts. Do you think it could be the cancer? Or I'm having these vague pains down there. Do you think it's the cancer? And if that type of thing is constant, it's probably not a good idea to watch this because it's ruining your quality of life just knowing you have it, even though cancer itself may not progress. There's always a psychological component to it. There's a fear also that a progression may occur even under surveillance. Is that possible? Well, with today's methods and the advancement of methods in the future, it's unlikely that this will occur, but it's still an honest fear that will keep men from undergoing active surveillance. The PROTECT study and other studies say it's safe, but it's not perfect, just like nothing in medicine is 100%. Active surveillance also requires lifelong testing and follow-up, so it's something that never ends. The time period between when studies are done can get longer and longer as the disease goes out further, because it's unlikely it's going to change 15 years if it hasn't changed in 10 years, let's say. So, but this is a constant thing. So it's always something that you have. It's almost becoming, rather than, a fatal disease, it can become a chronic disease that has to be continually monitored and checked. So I think that these are the reasons that, men would not want to undergo any type of active surveillance. So what you really have to decide is, when you talk to your doctor after a diagnosis, if you are a candidate for active surveillance, to understand what that entails. You have to weigh the risks and the benefits to you as a person, not as a group of people, and how it's going to affect your life and your family's life. I always recommend, when you go in and talk to your doctor about a cancer diagnosis, always bring family members with you, because it's very disconcerting when somebody tells you you've got cancer. And a lot of times that's what you can think about. That's all you hear. So please make it a point to always bring somebody with you that can ask some of the questions that you may not be, able to answer, or, you have difficulty verbalizing because you're thinking about your cancer. But it's really important to do that and to educate yourself about all the different treatments, not just active surveillance. I hope this has become a good explanation of what active surveillance is. And there's a lot of good information on various websites. One of the best ones I can definitely point you to is the ZERO website, which has just a lot of good information and videos discussing active surveillance, as well as any other kinds of treatment for your prostate cancer. And always be ready to seek a second opinion. You're not going to hurt your doctor's feelings if you feel that you just want to hear something from someone else. It's very important to do that. You can always go back to the doctor that you've seen that made the diagnosis. Again, it's nice to hear the same information from a lot of different people so that you feel comfortable with whatever decision you make, whether it's active surveillance or more definitive treatment. So I want to conclude with this. Active surveillance is a great form of treatment, and consider it a form of treatment if you have low risk and early stage prostate cancer. You can have management of your disease with minimal or no impact to the quality of your life. Like Bob. Bob went on and had a wonderful life, and he had none of the problems associated with any of the treatments of prostate cancer. He's very comfortable watching this, and although I'm not taking care of Bob anymore, one of my colleagues is, and he's continuing on his active surveillance protocol, and is very happy that he did just what he did, even though it started well before active surveillance was accepted. And I give him a lot of credit for even bringing it to my attention before active surveillance was something that was well accepted amongst the medical community. So talk to your doctor and see if active surveillance may be right for you. And I want to thank you for your time, and good luck and best wishes to you and your family with your future journey.